Welcome everyone to the fifth session of the RCC webinar series. Today, I'm going to be presenting what we recommend that you should review as part of your brain plans to ensure that you have a high quality plan. I am broadcasting from sunny South Florida in the United States, and I would like to welcome everyone. So, salam alaikum, bonjour, and marhaba to everyone. This is a little information about me, but Justin has already mentioned it. But I just wanted to indicate that even though some of the slides that I'm going to show today are mostly about Variant systems, I'm not paid by Variant, and I'm not promoting Variant. I have worked with both Variant and Electa Linux and different treatment planning systems like Monaco, Eclipse, and BrainLab. And Pinnacle. So, I mean, some of the things that I will show you may be more specific to Eclipse, but that doesn't mean that you cannot do them with the other systems. And the other thing I wanted to let you know is that pediatric cases are not going to be discussed in this presentation. There's a presentation, I think it's towards the end of the series, that will focus on pediatric cases. All right, by now you're probably very familiar with this slide, but I just, we always want to show you because this is the order in which we feel that one should perform the checks when you're trying to look for, when you're trying to evaluate the plan that you're going to deliver on patients, right? So you're going to start with patient assessment, then you're going to go to simulation, treatment planning, and then we have two further sections, communications and communication and deviations. All right, so when I started working in the field and somebody told me to check a plan, the first thing I did was go and look at the plan, right? But that's actually not a very good idea because how can you evaluate a plan if you don't know the specifics that motivated the changes or the strategies that were used in that plan, right? So the first place where you should start should be by looking at the patient medical history. And you can do that by looking at a series of documents, right? The first one, which is probably a good place to start, is the note that the doctor wrote, the radiation oncologist wrote when the radiation oncologist interviewed the patient for, and determined what type of plan he wanted to use with this patient. That document, I mean, we call it consult. In some places they call it and progress notes. They may have different names in different places, but basically it's a summary of the situation, what's ailing the patient, what type of previous treatments the patient has had, what type of imaging maybe the patient has had, and a summary of what the plan is for treating this patient. But that's not sufficient, right? You should also go and look at the physician's prescription or medical directive, and this is where the physician indicates what fraction size and fraction numbers he or she is planning on using, what type of treatment modality, and so on. You should also look at the physician's orders for simulation, setup, and imaging so that you know what type of setup was used and maybe some specifics that the physician wants to focus on, like maybe there's an organ at risk that the patient that needs to be avoided, or and so on. In the case of brain cases, which is what we're focusing today, you should definitely look at the MRI report, right? Particularly when we're dealing with treating metastasis in the brain, because you need to know where the metastases are located, right? And how many there are. You should also look at the surgical reports, right? So why should we do this? I mean, why should we check all these things? Well, for example, if in the MRI report, it may mention a lesion that was not contoured, right? When you're looking at the contours, you may find that the MRI report indicated 5 lesions, but there's only 3 that are contoured, right? There may be a reason for that, so that's something that you need to investigate. Or the opposite situation, you may see something that looks like a lesion that was contoured, right? But it's not mentioned in the MRI report, so that needs to be investigated. Maybe the MRI was repeated, right? And the image that is most recent was not used in contouring or planning. It's possible that the patient had surgery, but the MRI that you're looking at was acquired prior to the surgery. It's possible that the patient is claustrophobic and we're planning on using, or we are using a full face mask, right? It's also possible that the patient has back problems and cannot lay flat. So all of these things are going to affect how we design the treatment plan and how we make the treatment plan optimal for the patient. Something else that you're going to look when you're researching the medical history of the patient is if there are any specific factors that may impact how you're going to treat this patient, right? Does the patient have any implanted devices like cardiac devices or nerve stimulators that may affect where you can place your radiation, right? Does the patient have any implanted hardware? Maybe they had back surgery, right? Spine surgery due to an accident. Maybe they have dentures, right? That can be maybe removed or they have to be left in, right, during treatment. Look at the patient previous surgeries that may affect maybe even though you're treating the brain, right? If the patient had a surgery on their back, it may be difficult for the patient to lay flat, right? For an extended period of time comfortably. Is the patient taking any medications like for anxiety or for pain, right? Then it's important that you know that, so that if the patient is exhibiting signs of anxiety, maybe it is because they forgot to take their medication. And of course, if they're anxious, it's going to be very difficult to have them lay still. If a patient has kyphosis, you're going to have the same issue, right? They cannot lay flat. My recommendation is to always follow the AAPM report TG203, right? And I'm giving you the reference at the bottom here, so you'll have a copy of the presentation, or when you watch the video of the presentation, or you can take a screenshot. This is a very good resource document to have. The picture that I show you here is an example of the patient card when the patient has an implanted device. In this case, it's a Boston Scientific cardiac device, right? So it's important when the patient comes in for the first visit that somebody scans that card so you have access to that information. And if you don't have it, then request it. The other thing that you should be looking at before you even look at the current treatment plan is to see if the patient has been treated before. If the patient has been treated before, you have to see where was the patient treated, right? Because maybe the patient was treated at a location that is far away from the head, and then you don't have to worry about it. But if the patient was treated for head and neck, then that's very relevant, right? Or if the patient has previous brain treatments. If that is the case, it's essential that you obtain the DICOM files from the previous treatments, such as the CT, the RT plan, the RT dose, which is where the dose is stored, and the RT struct, which is where the contours are stored. You should perform a CT to CT rigid registration, right? For brain, the formal registration is almost never used. I mean, it should only be used in very, very specific cases where you have no other option. But for brains, rigid registration is more than sufficient. You should always see where the previous dose fell relative to where you're treating now, right? You want to evaluate if there's any overlap. And what's really, really important is that you look where the low dose isodose lines are falling, because you may think, oh, that's just low dose, but you're adding it to maybe medium to high or even the low dose levels from the new plan, right? So now something that was only a few gray now becomes, 10 gray. You should also try, when possible, to calculate new constraints for the new plan. This will help dosimetry create a plan that is more in line with consideration of the previous doses that some of the organs have received. All right. Now, the challenge with this is that most treatment planning systems do not work with biological dose, which is the correct dose to use when you're adding doses from different plans, particularly when these plans were calculated with different fraction sizes. All right. I'm giving you on this slide, you can actually, can you see my mouse, or do I have to use like a special pointer for this? I didn't think of that. Let's see. Oh, pointer options. Here we go. Okay. All right. So I'm giving you two very, very, very useful resources. You will be happy that if you take a screenshot of this. The first resource is a document where they explain step by step how one should do an analysis of previous irradiations. Right? There's no consensus on how to do this, and this is the only guiding document that's available right now. The other resource that I am giving you is a webinar series that was provided by ESTRO, and ESTRO is the European Society for Radiotherapy and Oncology. It was started last year, and it's finishing this year, still going on. I'm giving you the link to that, where you can see presentations by top experts on how one should deal with cases of re-irradiation. Very, very important.
Jose?
Yes.
We have a couple of questions in the chat. Let me read off the first one and I'll let you fill it. And
Sure.
That is, can we do stereotactic radiotherapy for brain cancer patients who take 30 gray and 10 fractions for the entire brain? So this is SRS after whole brain.
I believe so. I believe there are some publications on how to do that. Yes. And of course, you would have to treat that case as a re-radiation case, following the process that is that I've just pointed out in this paper by Paradis and others, 2019.
And I agree. I mean, the early clinical trials for SRS to brain metastasis was the addition of SRS after whole brain RT. So that guidance is out there.
Yeah.
There is another question. And that is, what are the specific situations for deformable registration in the brain?
Right. So I'm going to show you some examples later on, but basically, if you think about the brain when you're looking at a CT, the right and we're bilateral organisms, right? So we have bilateral symmetry. So the right and left side of the brain should look the same, right? Pretty much. If a patient has had swelling or surgery, then there's going to be a deformation of one of the sides relative to the other, right? So there, you may have a situation in which the patient has had prior surgery or maybe swelling, and now the swelling has changed, right? And maybe you're trying to relate doses to areas that, the previous treatment was done with a CT where the brain did not have surgery, and then the second treatment was done after surgery, right? So in such a case, the brain doesn't look the same in the two doses, right, that you're trying to add. So in a situation like that, then you might have to use the deformation. The thing about the problem with deformation is that it has to be done very, very carefully. So always make sure that you're matching or mapping the correct voxel, in the anatomy in both images, right? So because you could have a major discrepancy, right, between where you're placing the those. Now, I have not necessarily, I don't remember ever seeing a case where I had to use deformable registration, but I can imagine that it is possible. So that's the reason I mention it. But I've always used rigid for most cases. And even in cases like that, like the one I just described, you may still be able to do just a rigid registration, just understanding that you're only focusing it on a specific area of the brain that has not changed, and ignore the part that looks very different.
Thank you, Jose. There's one more question, and maybe this is best addressed later in your talk, but let me go ahead and ask. Is there a time limit beyond which we no longer consider the dose from the prior radiotherapy?
Yes, that is actually explained in the paper by Paradis, the 2019 Advances in Radiation Oncology reference that I give you there. They have proposed dose discounts that you can use based on the number of years or the number of months since the radiation was given. The thing is, even in this paper, they mention it to use it with caution, because these are numbers that they just came up with, from their staff, right? From the radiation oncologists coming together and agreeing on something. But there's no, there is some clinical basis for it, but it's basically subjective, right? There's no papers or studies that you can rely on to say, okay, yeah, it's okay to do this. I can tell you when I've worked with different physicians that some physicians feel comfortable using the dose discounts that are indicated in this paper, and some physicians are not. So in those cases, then you just assume that the dose was given recently, right? But it's reasonable when you think about it, right? It's reasonable that some repair has taken place, right? From the time that the patient was treated to the time in which you have to give the patient a new treatment, right? So that if you consider the full dose, you're always overestimating, right? What that organ received.
Thank you, Jose.
Oh, I'm sorry, by the way, they do discuss this topic in the webinar series by Estro as well. All right, so I think we're ready for the first poll question, right, Justin?
Yes.
All right, so, oops, for some reason, my slides aren't, they're not moving. Oh, okay. All right, so for some reason, I can't switch to my next slide. I don't know what's happening, but all right, so the question is the first item to complete when performing a quality check is, and the options are inspect the DVH to determine if OIR constraints were met, review image registrations, perform a second check calculation of the plan, or review the patient's medical history.
Okay, so we're at about half of the participants responding right now, with many more of those answers coming in. Let's see, Jose, if we can use this pause to advance your slide deck.
Yeah, I'm not sure why it's not. I'm not sure what's that. Oh, I think I'm back. Let's see.
Is it the pointer?
There we go. Yeah, it was a pointer. You can see the slide now, right?
Yes.
Okay.
Okay, so we are well over half now in terms of the response rate. Let me end the poll and share the results. Okay, and so Jose, would you agree that number 4 is correct?
Yeah, let me see if I can. There we go. If I close it, I don't know if it's gonna close it on everybody, but I'm just gonna close this window. Did I close the poll for everybody?
Yes,
Oh, okay.
and that's just fine.
All right. So most people selected answer number 4, which is correct. Remember that when I started the presentation, I mentioned that I said, one would think that, when you want to check the treatment plan quality, that you just go directly to the treatment plan. But the thing is, there's a lot of factors that affect how that treatment plan was designed. And you're not going to know what those are if you don't review the patient's medical history. You have to know the situation of the specific situation for the patient to really understand if that plan is really the best plan that we can give the patient. All right, so the first place to start is always without any exception, to review the patient's medical history. All right, so we've reviewed the patient's medical history. Patient has been simulated. So we should review the simulation images, right? In the case of brain, you want to make sure that the head is level, right? Level means that it's straight as possible. Notice that there's a little bit of an angle in the example image that I give you. Ideally, you want it as flat as possible. And the reason for that is if the chin is too high up, the saliva has a tendency to slide down onto the throat, and it makes some of the patients uncomfortable, and it makes some of the patients cough, which you don't want to do when you're treating the patient. You want to make sure the mask is in tight contact at the forehead and the chin. Those are the most important points. You may be treating with a full face mask, or you may be treating with an open face mask like the one I'm showing you here. The open face mask is really nice for patients that are claustrophobic. It really helps them, go through the procedure a lot more calm. Notice that there's straps, right, designed into the mask. One strap is on the chin that is thick. It looks different, right, than the rest of the mask, right? These are very, very important because they're thicker, they're a lot harder, right? And those are the ones that are gonna hold the head in place. Very, very important for SRS and SRT treatments, as we want sub-millimeter accuracy. All right, you want to make sure that the back of the head, right, and the neck is conformal with the headrest, and also with the custom pillow, right? The Acuform pillow. You want to make sure that there's no gaps. When a patient has long hair, You want to make sure you don't bunch the hair right under on the back of the head between the head and the pillow, because that makes the reproducibility, the day-to-day setup of the patient, very variable. You notice in the picture that I gave you that the hair of this patient has been put into a ponytail and extended outside of the back of the mask. You should treat the patient in the same way every day. So if the hair was in a specific way, you have to maintain it that way. It's very important that the patient does not cut their hair or change their hairstyle during treatment, because that will affect the reproducibility of the setup, right? And for patients that have facial hairs like beards and mustaches, it's very important that when you create this mask, that it's pushed down so that the chin is not touching the beard, but actually touching the skin of the patient. So the beard should be completely squashed at the chin point. So here's an example of why you should always look at the CT simulation images. Here's an example of a patient that when they simulated the patient, the head is too far to one side of the head frame, right? Now, it is possible that this may not affect anything if the patient is comfortable, but typically the plastic, or what, not plastic, sorry, but the material that the head frame is made of may be actually pushing against the patient's head, making it very uncomfortable during treatment. So a better way to do it is always making sure that it's nicely centered, right? In this case, the patient's head was slightly tilted to one side. It's not a big deal. It's ideally, it's nice when it's perfectly straight. But at least the pillow, right, is conformal on both sides. There's space between the head frame and the head, right? You want to make sure that that is the case. It's better to be present during simulation so that you don't have to bring the patient back to be simulated, right? If you were present during simulation and you saw this, you would just throw the mask and the pillow out and make a new one, right? And it wouldn't be a problem. But if you see it after the fact, then the patient is going to have to be brought back in and resimulated. All right. The next thing you want to evaluate is the image quality, right? In the case of CT, you want to make sure that the slice thickness is appropriate, right? If you're treating SRS and SFRT, SFRT stands for stereotactic fractionated radiation therapy, right? So SRS is for one fraction, and SFRT is for more than one fraction. Could be 3, could be 5, right? Typically. Right, for those cases, you want the slice thickness to be ideally 1 millimeter, but at least less than 2 millimeters. For cases that are not SRS and not SFRT, less than 4 millimeters is appropriate. And most places do 3 millimeters. You want to make sure that the field of view is close to the head, right? If your field of view is too big, then your in-plane resolution is coarser, right, than if your field of view is closer or zoomed in to the patient's head, right? So that's why that is important. You also want to look for image artifacts, right? And we'll talk a little bit more about that later. You want to make sure that you can see the tumor, right? Well, if it's a CT, can you see the tumor? Not always, right? If it's a cavity, you're definitely going to be able to see it, right? Some tumors are actually visible in CT. In some cases, maybe iodine contrast was used, which makes the tumor visible in CT. Right? You want to also evaluate the quality of the MR images. It's very important that the MR images are acquired in orthogonal slices. Like if you let the MR technologists take images of a patient's brain, they're going to do it using diagnostic protocols. And these diagnostic protocols are designed so that you can see everything in one slice. So the slice is going to be angled. And they're usually thicker than what you want, right? Because in MRI, the thicker the slice, the clearer, the sharper the image, right? But for our case, for what we need, we want to make sure the slices are orthogonal. That means at right angles, right? Just like the CT images. Why do we want to do that? Because we're going to be fusing the images. You're going to get much better fusion, better quality fusion, if the slices are orthogonal. right? Spatial resolution, we want it better than 2 millimeters for SRS and SFRT. What kind of artifacts can you expect in MRI? Motion artifacts, geometric distortions, right? Those are very typical. And then you want to make sure that the appropriate sequences were used, right? And that the lesions are visible. I have seen MRIs where you couldn't see the lesions, so they're not very useful. I mean, they're useful for drawing the organs at risk, but if you cannot see the lesions, I don't know what you're going to do with them, right? So always check that you can actually see them. Now, how are you going to know that the lesions are visible? Well, you have to look at the MRI report first, right, to see where the lesions are located, to find them. Sometimes, in this picture that you have here, the lesions are very clear, right? But there are some cases in which the lesions are very small. There's a lot of little white, bright dots in the brain. So it's going to be very difficult to know if you're looking at a lesion or if you're looking at something that is something else. So always rely on that radiology report. All right, I'm going to talk to you about, obviously, it's outside of the scope of this presentation to give you a full training or full explanation of every MR image and how it's used for brain. So I'm just going to give you the most important ones, right? The most basic ones. So the first one is the T1 weighted image with gadolinium contrast. Now, why is this image important? Because the edge of the tumor shows up bright on the image. See, this patient has a lot of tumors, and you can see the outline, right, of the tumor, right, for each one of these. You see the white line and then a dark center, right? So that's an indication of the tumor. Now, why do you see it like that? Because gadolinium will accumulate in the edge of the tumor, right? Because you have the blood-brain barrier, right? Now, this sequence, like I say here, it's sufficient for contouring metastasis and tumors that do not have or do not involve hemorrhage, right? Hemorrhage means like blood or other fluids are coming out of it. The other thing to consider is that depending on what MR scanner you have, you may have different names for the images, right? In some may be called MP-RAGE, some may be called T1 field spin echo, and there's this space protocol now that is more recent but I don't remember what vendor has that. I don't know if it's Philips or what's the other one? I'm not sure. All right, so the T1 weighted is the most basic, right, of the MR images that should be included in your image set. The second one is the T2 weighted image. In the T2 weighted image, the fluid shows up bright, right? I'm showing you here an example. I have a T1 with gadolinium next to the other two images so you can see the contrast, right? You see the in the T1 image with gadolinium, the fluid inside of the ventricles is dark. But in the T2, the fluid shows up bright, right? In the T1, you can see the edge of the tumor, very nice. Notice how it looks different in the T2, right? So that's why you don't want to draw the edge of the tumor on T2 because you don't see it as clearly. However, what you can see very clearly is that you have fluid, right, around the tumor, right? In some cases, you want that fluid to be included in the contour, and in some cases, you don't, right? The physician will be the one who would know in which case you need it included and in which case you don't. The reason you want it included in some cases is because sometimes cancer cells exist inside of that fluid. So we want to make sure we take care of those as well, right? And I'm giving you another example here, the T2 flare, right? In the T2 flare, notice what happens, right? The CSF, right? That's the fluid inside of the ventricle is dark, right? But the fluid around the tumor is bright, right? So what's the difference? So the difference is, in this case, what we're looking at is purely the edema, right? The edema means the blood or fluid that is coming as a result of this tumor, in this case, a GBM, right? But it does not include CSF, right? It excludes it. So it makes for more accurate. If you have to include the edema, this would be the place where you would contour, right, to make sure it's included. All right, so this is what I was talking about a moment ago in regards to your question on the formal registration, right? Here you have a case in which a patient had prior either surgery or maybe this is a GBM and this is fluid, right, or edema that's outside of it. And notice that the swelling caused by the presence of this has made the right and left side of the brain to look different, right? At the top, it looks kind of similar, right? It looks kind of almost the same. I mean, you can see it's a little bit more squeezed over here, but you're missing a whole ventricle here, right? So if you had to do a registration between an image like this and an image where you have symmetry, you have no choice but to use the formal registration, right? Typically, you don't have to because you'll have pre and post surgery images. So that shouldn't be a case, but you never know. All right. All right. The other thing that you have to make sure is that the correct images were transferred or imported, right, from your PAC system. The PAC system is, I mean, I don't know if it's called the same thing where you work, you know, where we work, it's called PACs. And basically it's where you store all the medical images. In some cases, the patients may bring the images in CDs, right? So you have a lot of different ways of importing the wrong images, right? So you always have to be very careful. Always look at dates. Make sure the dates are correct, right? If the patient had surgery, look at the surgery date. Look at your image dates. Is it pre-surgery or post-surgery? Your physician may ask you, it's like, oh, where are the pre-surgery images, right? So you have to be ready to make sure that they're available for the physician to make the appropriate contours. All right, the DICOM header information, right, is very, very useful because sometimes you may not have the document or the CD, and then you're like, okay, I don't know when these images were taken. So always, you can always, most treatment planning systems have the ability to look at to read the DICOM header, and if they don't, there's always free third-party software that you can use to read the DICOM header, and that will tell you where the scan took place, who did the scan, if contrast was used, the dates, right, the slice counts, all that information will be there. All right, so we're ready for our second poll question. All right, and the question is, which of the following is important regarding CT simulation for brain cases? The head tilt, the mask conformality with the patient's chin and forehead, long hair in a ponytail pulled outside of the mask, centering of the patient on the custom pillow and mask, if the patient had prior surgery, or all of the above.
Okay, we have a great response rate. I'm going to end the poll.
Yeah, I think we can end it. All right, so most people did great. Okay, you got all of the above. That is correct. All of these things are important. One is not more important than others. All of them are important at the same time. So please always make sure that you're checking all of these things. Again, just as a reminder, that's why it's important to be present, right, at each one of the phases of the patient. If you're present during CT sim, then you can correct all of these things if any of these things have not been done, right, before they actually you actually even doing you know, before the planning even starts. Otherwise, you have to bring the patient back and redo the whole thing. Why isn't it? Okay, there we go. No, there we go. Yeah, all of the above. All right, so now we're making it closer to where most people start checking a plan, which is the treatment plan, right? All right, so first thing you should check, especially when you're in regards to brain, is to check the image registrations that were performed, right? In some clinics, maybe you did the image registration, then you checked it, obviously, but maybe a dosimetrist did the image registration, right? So regardless, they should be checked, all right? And like I said, rigid registration is almost always sufficient. So if you see if somebody used deformable, always question it. Always make sure that there's a good rationale for having used deformable. Always check that the correct images were registered, right? Even if the correct images were imported, it doesn't mean that the correct images were fused, right? So always check that the fusions were done with the correct images. Now, I probably should have put this in image quality, but it's important that if you're doing image registration, you're going to get better registration if the images have similar slice thickness and in-plane resolution. If you're registering thicker with thinner images, you don't get as good of a registration. It doesn't mean that the registration is bad, but it's not as good, okay? So if you want really high quality You want to make sure that they're the same slice thickness or very, very close. Always consider the impact of uncertainties in the registrations, right? You have to understand the limitations that you have with your registrations. For example, when you're fusing MRI to CT, right? You always have to consider that you have distortions in the MRI, right? So where you see some of the voxels may not be exactly where they actually are, right? So for MRI images, I don't think you can get better than 1 millimeter, right? So if you have a fusion, you already have a setup uncertainty of a millimeter just because you're using fusion. There's a very good resource that I'm providing you here from the APN Task Group 132, right? So I would definitely encourage you to get this document if you can, to learn about how to determine the inaccuracies and accuracies of image registration. All right, the next thing you should be checking are the contours, right? In this first step of the check, you're not checking the quality of the contours, meaning you're not checking that the contours were drawn correctly. You're just checking that the correct contours were, sorry, that the correct structures were contoured, right? So how do you know that the correct structures were contoured? Well, you can look at published guidelines, right? Or your RTOG reports or whatever, you know, specific to what you're treating to make sure that the correct tissues and organs were contoured, all right? And that they were given appropriate names, right? It's very important to be consistent in how you name structures. And it's also very important that the right and left are not switched. If for some reason an organ at risk was not contoured, you should always ask for the reason. Was there a specific reason that we're not contouring this organ? If there's a good reason for it, then we go ahead. If there's not a good reason, then it needs to be contoured. All right, in this second phase, now is where we're looking at the quality, right? Was it drawn correctly, right? So in the case of brain, you want to look at the fusion of CT and MR, right? Because some of the structures are more clear on MR than they are on CT. You also want to make sure that the contours were done appropriately. So how do you know that that is the case? Once again, you have to refer to contouring atlases, consensus guidelines, or both, right? And also remember, this is very important, that there's a lot of structures in the brain that are very small, like the optic nerves, the optic chiasm, the lenses and whatnot, right? So we need high resolution structures, right, for these. A lot of the lesions that we contour are also very small. So that's another reason why you want to use high resolution. Always look for incomplete contours, right? So it's very easy, especially if you're going to be just contouring some slices and then interpolating. It's very important that to make sure that you didn't skip one, right? In some cases, you can skip several slices and not even realize it, right? The other thing that happens very often, particularly when the physician is contouring some things, or actually even when we do it, is you have 3 planes, right, on your image. And then when you want to look at one, you have to click on it, right? And when you click on it, if you had your contouring tool active, you leave a dot there, right? So it's very important to also make sure that the post-processing was done and all the little dots were cleaned up. And then finally, something that is very, very important is just remember that not everything that is bright is a metastasis, right? It's important to consult with specialists that actually know how to do these things. I'm giving you a couple of good resources here, right, for naming the structures and what structures should be there and so on. The other thing you need to review are the PTV margins, right? Typically, I mean, I've seen 2 millimeter margins. I know that there's still a lot of old school people doing 0 margins, which is very scary. But sometimes they do have a rationale for doing that. So I'm not saying it's wrong, but it's not definitely what I would do. And how do you know that your margin is appropriate? Well, it depends on what you're treating, right? But I can tell you a very good example. When you're treating a multi-med case with a single isocenter, residual rotations are very important. What is the residual rotation? When you set up your patient, you have your 6 degree of freedom couch, you adjust the pitch, you adjust the roll, you adjust the rotation, but there's always a leftover angle that hasn't been corrected, right? If you re-cone beam CT the patient, you're gonna get a deviation, right? In pitch and roll, maybe. You're not going to get exactly 0, right? In some cases, maybe that residual rotation doesn't matter, but in some cases it might. In the picture that I'm showing you here, you can see where the contours are relative to where the patient would be treated if the rotations were not corrected. And you can see for lesions that are far away from the isocenter, like this green one and this orange one, you're completely missing them. So you're actually not treating them at all. Right? So very, very important to take care of these things. I'm giving you a resource here by Chang and a resource here by Justin, actually, on guidance of how to handle these cases. All right, so we're ready for poll question number 3. Is this a good decision? All right, so you're reviewing a plan for a patient with multiple metastases where some are 9 centimeters apart. Your physician wants to treat with a single isocenter. She suggests increasing the PTV margin from 2 to 3 millimeters in the lesions that are far apart to account for setup and localization uncertainty. Since it's a very small increase in margin, you decide it's okay to treat with a single isocenter. I like the maybe option. Maybe. It's really a yes or no question. Maybe it's a way to get away from having to answer.
Okay, we have a good response right now. I'm going to share these results.
All right, so I can see that the majority of people have selected no. Some people selected yes, and some people were scared to choose yes or no, so they said maybe. By the way, this actually has happened to me. This is the reason I'm putting it here. I mean, when you think 2 to 3 millimeters, I mean, it's a millimeter, right? What's the big deal, right? Well, let's see. Oops, hold on. Okay, I'm gonna be able to go. There we go. All right. So my answer to this is typically it's no. Now, why is that? Well, you have to consider multiple factors, right? Are the lesions large or small, right? Increasing the PTV margin from 2 to 3 millimeters for a 2 cubic centimeter metastasis is a 40% increase in volume. That's a pretty large increase in volume, right? Do you have a 6 degree of freedom couch to correct for rotations? If you don't, then it's a bad decision. If you do, well, it depends, right? Maybe if you're able to correct your rotations below a residual angle that guarantees that your margin is sufficient, then maybe that's okay, right? And the other question is, are the lesions close to an organ at risk, right? So I love this picture. I cannot remember where I got it from, and I feel bad about not giving the person credit for who created this image. But this is an image of an orange and the peel, and the volume of the orange is the same as the volume of the peel, right? So when you think about margins, think about that, because you're treating that much normal brain, right, when you don't really have to, right? You want to treat this, but you're treating this plus all of that, right? So just a small increase in margin can result in a very large increase in normal brain that you're treating to therapeutic doses, right? So always take all of those factors into consideration. It's not a simple question to answer quickly, right? You really have to look at the situation very, very carefully.
Jose, we have a question in the chat, and that is, what is the maximum rotation allowed of the 6-DOF couch?
Yeah, so it's not the maximum rotation. Oh, you mean allowed, meaning like you don't want to do more than what the couch can do? I mean, I know the couch can rotate at most 3 degrees in each one of, sorry, in roll and pitch. Obviously, for the couch kick, you can rotate whatever you want, right? But for roll and pitch, the most you can rotate with your 6 degree, or the most you can correct, sorry, with your 6 degree of freedom couch is 3 degrees. And I know it doesn't go up to 3 degrees because we've been in situations like that and it didn't do it. So, but if you're saying what is acceptable, then for that, I would refer you back to this document by Chang, where they actually did an analysis of different, a mathematical analysis of metastasis at different distances from the isocenter, and they determined for which specific situations is a 2 millimeter margin appropriate, right? And when you do that calculation, it actually tells you what is the maximum residual angle that you can have and still be able to cover your target with the margin that you've selected. So I use that publication very often to determine if it's reasonable to increase the margin, or better to treat with 2 isocenters, right? So that you don't have to increase the margin, because the issue with the rotations is your distance to the isocenter, right? So if some of your lesions are close together and one lesion is very far apart, you can just treat that lesion with a separate isocenter. The drawback of doing that is that it takes longer to treat the patient, because now you're treating the patient with 2 separate plans. So that's 2 separate setups completely, right? So instead of half an hour, it takes you an hour, right? But in terms of plan quality, you're going to deliver a much better plan if you do it that way. So I don't have a one answer for that question. It depends on the distance from the lesion to the isocenter, primarily. All right. Now, regarding the external contour, right, which in Eclipse they call it body, in Monaco they call it external. I'm not sure what they call it, and I think in Pinnacle they call it external as well. So that's the contour of the patient, right? When you're dealing with brain, most of it, typically you treat the patient like I show you in this photograph. So you have a head frame that extends out beyond the couch. The couch is over here supporting the patient's back. So you don't go through the couch, right? But you do go through all of this stuff. Now, this is usually designed with a material that has very low radiation signature, right? It doesn't, it attenuates very lightly, but that doesn't mean it doesn't attenuate at all, right? In fact, when you're looking at the CT images, that you can see the sheets, right, of the that are on the patient. So obviously, it doesn't take much to attenuate, right, the beam. So it's good practice to include the head frame in your body contour. Why is that? Well, because if you don't include it, then it's not going to be part of the calculation, of the dose calculation, right? Will it make a difference? It depends. In some cases it might, in some cases it doesn't. It really depends on where your lesions are. It depends on how much of this material you're crossing through, right? So there's no clear-cut answer, which is why it's just safer just to do it, and then you don't have to worry about it. All right. A very easy way to do this is, I should mention, it's very important. I mean, you could say, oh, why don't I just draw a blocker on the patient and be done? It's like, yeah, okay, you could do that for dose, it's fine, right? The problem is if you're using surface guidance, you need to be able to see the outline of the face of the patient. You need to see the nose. You need to see all this topography, right? So you don't want this inside of a big block. Otherwise, you can't set up the patient with surface guidance, right? So what I usually do is I have my original contour of the patient that showed, the nose and the ears and whatever. And then I just draw like a big shape at one end of the device, and then I draw a shape on the other end, and then I just interpolate. Because it doesn't have to be conformal. You don't have to be drawing all the screws and everything. It's not necessary, right, for a dose calculation. So again, this is just good practice. If you don't do it, it doesn't mean you have a bad plan. Okay, it's not like, oh my God, what have I done? I've never done this before. I've mistreated patient. No, that's not true. It's just a safety thing. And it's an extra thing just so you don't have to worry about something that could affect the plan but maybe doesn't, right? All right, density overrides. Now, density overrides are not very common in brain treatments, but I'm just going to talk to you about some situations that you may encounter. Right. For example, it may be possible, rare, but possible, that you may have seen CTs where iodine was used so you could see the tumors, right? Here's an example of a patient, of a slice on the brain of a patient without on the left and with on the right, iodine contrast. And you can see, you cannot see the lesions, right, on the left side, but you can see them pretty clearly on the right, okay? Now, iodine has a atomic number of 53, so that's pretty high attenuation, right? So and this iodine is not going to be present necessarily, right, when you treat the patient. So what do you do? I mean, how do you handle this? Well, you could contour these lesions and then assign them a density of 1, right? So basically it was what we call overriding, right? Overriding the density. You could do that. Or maybe you acquired a CT of the patient without iodine and then with, right? So you will use the CT images with contrast to contour and identify localized lesions, and then you will plan it on your CT without iodine, all right? The drawback of this is that you're doubling the imaging dose on the patient, but, you know, I mean, that's more of a decision of your radiation oncologist, whether they feel comfortable with that or not. All right. Now, typically, we don't use iodine contrast in brain cases because we're using MRI images, and you can see the tumor clearly in MRI. But although rare, you could have situations where you may actually have no MRI images, right? Why? Maybe because there's no MRI scanner nearby where you're treating your patient. Maybe the insurance company won't pay for it. Maybe the patient is pregnant and then you don't want to use gadolinium. So you have all these, or maybe the patient had pre-existing medical conditions where a physician decided that the use of contrast was not indicated, right? So if you have a situation like that, then maybe you'll encounter yourself in this situation. Now, like I said, if you have 2 scans, one with and one without, just plan on the without and contour on the with. And if you only have the one with, then you're going to contour and then you're going to do a density override, right, to overcome the issues. There's very good resources, right, that I'm giving you right here, right? There's a paper where they talk about these types of situations. And the most recent ACR manual on contrast media gives you lots and lots of guidance of updated and recent information. And I can tell you that it's very important to read this one, because I was very surprised. I had always been taught that you shouldn't be treating patients with kidney function issues with contrast, and they're actually telling you the opposite. So definitely something to look at, okay? All right, the other type of contrast to consider is gadolinium contrast, which is the one that we use in MRI, right? Gadolinium contrast actually has a higher atomic number than iodine. It's actually 64, right? So it also attenuates X-rays. Now, do we have to worry about gadolinium when we're doing the CT of the patient? I mean, typically the CT and the MRI are not done on the same day, right? There's quite a few days in between. And the biological half-life of gadolinium is like 1.5 hours. So if the MR scan the patient one day and the following day they do the CT, you're gonna have probably more than 11 hours, and pretty much all the gadolinium is gone, right, from the patient. Now, for patients that have compromised renal function, it takes longer to eliminate the gadolinium from their system. According to the document that I showed you, the 2023 ACR manual on contrast media, they tell you it's about 2.5 days. So as long as you space the CT and the MRI by 3 days, you're good, right? Now, in general, right, even if gadolinium, if the patient had just been given a gadolinium injection and you're going to CT the patient, the concentration of gadolinium in the brain is pretty low. So it's quite likely that it will not have an effect on the A2 values in your CT. But just to be safe, you can always use these guidelines.
Jose, we have a question from the chat.
All right.
And that question is this. Using the BrainLab device during CT imaging, the mask is formed while the device is on the table. However, during treatment, the device is out of the couch. What are your thoughts on the accuracy and reproducibility in this case?
Yeah, I know what you're talking about, the infrared, the part that has the infrared balls. Yeah, that is actually designed to have a very, very low X-ray signature. Now, what I have done, just because I want to play it safe, is I include it, right? Because it doesn't really affect anything. So I included, we actually put it on when we're simulating the patient. that way the CT image also has the the attachment with the infrared spheres.
The attachment.
Yes. So but it's I don't think it's I think it's too small of an effect. And the thing too is again, it's going to depend. Do you go through it? Do you not go through it? Right. So it's going to be plan specific. But I don't think, I mean, it's specifically designed to have a very low attenuation, right? So I cannot imagine that it would affect your plan significantly regardless. But you could always do a phantom test with and without and do a plan on it and just see what you get, right? I don't know if there's a paper on that. I haven't looked for it, so I'm not really sure if there is one. Good question. All right. Regarding flash, right? Flash, I mean, it's more like when you're thinking of breast, right? But there is a brain case where you actually do use flash, and that's when you're treating whole brain, right? When you're treating whole brain. And by the way, flash, just in case, it's the gap that you leave between where you're closing your beam, right? Your jaws and your MLC, and where the edge of the scalp of the patient is, right? It's that airspace that you leave in there. So why do you do that? Why do you want to leave an airspace in there? Well, in the case of breast, you do it for motion, right? In the case of brain, you don't do it for motion because that head isn't going anywhere. You do it because you don't want the penumbra of your field to be in the brain. You want the penumbra to be outside, right? And by opening your aperture, you ensure that, okay? The other reason is more historical. Is I don't know how many of you have experienced this, or maybe you're still doing it, but sometimes patients were treated for whole brain by just using tape. You would just tape their head to the couch, and that's it. So that was the immobilization. So in those cases, this actually helps with a little bit with that setup uncertainty. Oh, by the way, I'm giving you a link here. I really like this website, dosepedia.com. They have some short videos that are like 15-minute longs, and they also have some longer ones on how to do treatment planning, tips on treatment planning. And even if you're not doing the treatment planning, it doesn't matter. You're still going to benefit by watching it because you're going to understand why the dosimetrist has done certain things in the plan, right? It'll make a lot more sense. So I strongly recommend going to something like this.
Jose, there's a question in the chat that's asking
right.
about flash. And
Yes.
so why do we even have flash in the first place? And what does flash mean? I mean, when I see flash, there's so much hype now around these ultra high dose rate radiation therapy plans. Sometimes I don't even think back to conventional flash.
Yeah, I mean, the way I understand it is so that you don't want the penumbra on the brain. That's pretty much, I mean, that's the reason that I think it's used for. But I
Yeah.
mean, if there's another reason, I don't know it.
And I think some of it's historical. I mean, back in the old days when we just simply did not have the imaging available on the machines, nor nearly as good of a mobilization, this flash or this extra margin made sure that we didn't miss.
Yeah. I mean, you want to get full dose on the brain. I mean, that's the objective. You don't want to get 90%. You want to get 100%. You know what I'm saying?
Okay.
So that's you. So basically you're extending your 100% outside of the patient's head, right, on purpose, so that you can't give 90%, right?
Looks like we have Dr. Ben Lee on the call, and he has his hand raised to ask a question. Dr. Lee, please.
Oh, thank you. This is a great question about flash for the brain because the brain holds still. If we're doing daily imaging, we can get the alignment. So we're not so much worried about swelling or movement. So why do we always do flash? And it turns out that actually you can do whole brain without flash. You may risk having lower dose at the sort of the periphery of the brain. But at UCSF, actually, one of my mentors showed me that when she has a patient and she's not worried about marginal misses in the brain, she will sometimes treat patients without flash. And what that does is that protects the scalp from having as high of dose and prevents permanent alopecia along sort of the mohawk of someone's head. So it can be considered. You'd have to use your clinical judgment though for when is that trade-off worth it? When is it worth it protecting the person's hair? And if someone you're really worried about, they could have metastases anywhere, even at the edges of the head, you want to include the flash.
Thank you, Dr. Lee.
Thank you, Dr. Lee. That was very good.
And there's a follow-up question that really is an extension of that explanation, and that is, do we need to use flash for whole brain VMAT? And I think this may be in the context of hippocampal avoidance.
Yeah, and well, I actually didn't know until we discussed it in our group that there were cases in which flash was used for whole brain VMAT, because the centers that I worked at didn't use flash for VMAT, right? So I guess I may not be the best person to answer this question, since I'm not. I mean, I've never seen a case yet, right, where I worked at a center that actually used flash for VMAT cases.
That's not our practice at Emory. So we do not use flash. We use very rigid immobilization with the mask and imaging for patients set up in conjunction with the robotic couch. So no flash for our VMAT, whole brains.
Yes, I apologize. I don't have experience on it, so I won't be able to give you a good answer.
Okay, and there's another question about flash, and that is can we open the flash in all brain states, 3D, GBM, question mark?
Well, when you're treating a GBM, you're not treating the whole brain. So, but if you're saying if the lesion is close to the scalp, I mean, then I would follow what Dr. Lee has just mentioned, right? It depends on whether or not you're concerned that the edge, right, close to the scalp is going to get enough dose versus, hair loss, right? I mean, so I guess they're gonna have to weigh the two factors. But I've never seen flash for partial brain. I've only seen it for whole brain, right? And I'm just saying, just because I haven't seen it, it doesn't mean it's not done, right? Are we good to move on to the next? All right.
Yes, please.
All right, so now we're getting to the part that most people are familiar with, which is checking the beam settings, right? Now, in this case, we're looking at the treatment technique, right? And we're talking about appropriateness. Okay, so what do we mean? Well, so what's the standard, right? I mean, how do you typically treat these things, right? Well, whole brain is typically 3D with opposed laterals. That's the classical way, right? I mean, there are other ways of treating it, of course, but this is the most common way that I've seen. For whole brain with hippocampal sparing, it can either be IMRT or VMAT. Partial brain, same thing, IMRT or VMAT. Single metastasis, either dynamic conformal arcs or VMAT. And by the way, I explained what these acronyms mean at the bottom of the slide, just in case. All right. Cones, usually for trigeminal neuralgia or very, very small brain mets, right? And then a single isocenter with multiple metastasis is typically VMAT, but you can get equivalent plans with dynamic conformal arcs, right? The only drawback is that it typically may require more arcs, which means it takes longer, right, to deliver sometimes. All right, so let's look at some beam arrangements for whole brain 3D, parallel post beams. That's what I'm showing you there. The one thing to look for is that the beam angles are not set perfectly to 270 and 90 on both sides. And why is that? Well, if you look at the image on the left, the beams were set perfectly to 90 and 270, the opposed beams. And notice how the edge of the beams, right, is coming really close to where the lenses are on the patient, right? But if you offset the angle by just a little bit, just 3 to 4 degrees on both sides, in this case 93 and 263, you get a perfectly horizontal line at the edge, right, of the field, and then you're far away. You guarantee that you're blocking the lenses of the patient. So that's the reason for doing that. Okay, and again, I'm just giving you the same reference here for those PDA where they explain that. All right, for whole brain 3D also, the isocenter is typically placed at approximately at the center of the brain. It doesn't have to be exact. The plan is usually normalized to the isocenter. And the irradiated volume, the volume that's getting the prescription, should include the first cervical vertebra, right, C1. Sometimes it may include the second cervical vertebra, and sometimes it may include more than that, depending on the extension of the tumor. So that's why it's important to always read the medical history, right? So you can understand why the field was opened up more or less, right, in the plan that you're looking at. For whole brain with hippocampal sparing, usually the way I've seen it treated is with VMAT with 2 coplanar arcs. The hippocampus, which I'm showing you here with the white arrows, right, is contoured as an avoidance region, right? We're trying to protect that. Why are we trying to protect the hippocampus? Well, because the hippocampus is responsible for learning and memory in patients. And there's been a lot of trials that have shown that patients that are treated with whole brain without protecting the structure usually have declines in cognitive function, right? Short-term memory. And since our patients live longer now than they ever have, which is a great thing, it's important to make sure that when they're living, that they have good quality of life. So we want to make sure that they don't lose cognitive function because of the treatment that we're giving them. All right. So that's the reason we do this. So the isocenter in these plans is usually placed, I've drawn a red arrow to indicate where the isocenter is. It's usually in the center of the 2 avoidance regions, right? And then you set your collimator angle so that the MLC blocks can block the hippocampus, right? So here's an example. You see how the collimator was set to a specific angle so that the leaves can really effectively block the shape of the hippocampus that was drawn. All right, I'm giving you really 2 very good references here for hippocampal sparing. Actually 3. You have RTOG 0933, and you have this paper by Dr. Huang, and then you have another video in Dospedia that actually explains how to do this. All right, if you're treating a partial brain or brain metastasis, typically you want to use non-coplanar arrangements. Non-coplanar means that you're rotating the couch, right? So if the couch is always at 0, that's coplanar. If the couch is at some other angles, then it's non-coplanar, right? And since we're doing non-coplanar arrangements, always verify that there's no collision with the gantry. Very, very important. Some of the checks, you could do them directly in the treatment planning station because they have a 3D diagram sometimes of the gantry and the couch and the patient, and you can an animation, and you can actually see how the gantry rotates around the patient. Right? The location of the beam or arc angles depends on where the target is, right? If you look at the pictures here, at the top row, I have a treatment of a left target, and in the bottom row, I have a treatment of the right target. So obviously it makes sense, right? If you're treating actually, did I switch these? No, it's correct. I have a terrible thing with right and left. I usually switch them, so I always have to think twice. So if you're treating a left target, it makes sense that your beam should be coming from the left, right? If you're treating a right target, it should make sense that your beams are coming from the right. Why does it matter? Well, why would you go across tissue that doesn't have to be irradiated to get to your target, right? That actually results in 2 problems. The first one is that you're irradiating tissues that don't need to be irradiated. Also, you're making it harder for the radiation to reach your target, right? So you want your incidence to be directly on the target, and you want exit dose, right, on your organs at risk. The other thing you want to make sure is that you don't have gantry and couch angle combinations where the lesions are blocking or shading each other, right? Because you're trying to get dose to one lesion, and then there's another one behind it, and it's only getting exit dose, right? So that's going to make your plan less good, right? I have some really good resources here, one on dynamic conformal arc planning and one on VMAT planning for multiple meds with single isocenter. Right? These are excellent resources. So where do you put your isocenter? Well, if you're treating a single lesion, at the center of the lesion, that's ideally where you want it. Why do you want it there? Because if you put it at the center of the lesion, you can guarantee minimal dose to the tissues around the target and maximal dose to the tissues in the target, right? And if you have multiple lesions, where do you put it? Typically at the geometrical center, right? Some cases at the center of mass, in some cases, like in this case where you have 2 large lesions and 1 small lesion, you probably want to place the isocenter closer to the smaller lesion. Why is that? Because the smaller lesion is going to suffer more if you have a residual rotation on the patient, right? You have a greater chance of partially covering it or missing it completely, right? It's harder to miss the larger lesions, right? So if you, in those cases, you may want to place it a little closer to the smaller lesion instead of the geometrical center. All right, beam deliverability. What do we mean by that? Okay, that means there has to be a good balance between the number of beams or arcs that you're using and the time that the patient will be on the couch. The longer the patient is on the couch, the more likely the patient is going to be moving, right? And if the patient moves during treatment, that's going to cause a delay. If you have surface guidance, you're going to get you're going to immediately know that the patient has moved. You're going to have to re-image the patient, to readjust the patient, to realign, sorry, the patient. So all of that causes more delays, right? If the patient is laying on the table for very long, sometimes they just can't take it anymore. We've had situations like that where they're like, no, take this mask off, I can't do it, right? So you don't want to be in a situation like that where you've delivered 2 arcs, you still have 2 more to go, and the patient doesn't want to be on the couch any longer, right? So to avoid all of those things, always try to strike a good balance between these two. Will you get a better plan with more arcs? Of course. I can do a plan with 100 arcs, that's beautiful, right? But it's not the gain that you're getting from those accuracy or conformality is not clinically significant. So there's no justification for doing that. Since many of these plans are non-coplanar, you have to be careful with collisions, right? There are commercial softwares available. VisionRT has MapRT, RadFormation has Collision Check. There may be others that I'm not familiar with. The picture that I'm showing you here is from MapRT, and it basically gives you, I know it's very small, so it's hard to see, but it gives you a diagram of couch and gantry angle combinations, and in red, it shows you where you're going to have a collision either with the couch or with the patient, right? So this information, you get it immediately after CT SIM, before the plan has even been created. So the dosimetrists can use this information to determine which angles and which arcs to use in the plan to avoid collisions. All right, here's a clinical example, something actually that happened to me. So, so I was the idiot who did this. All right, so which arcs are okay to treat? Left, middle, or right? I'm gonna give you a little bit of time. It's not a poll, I'm just giving you a little bit of time to think about it. And of course, I'll give you a hint, this has to do with collisions, right? All right, so the one in the center is the only one that is okay to treat with, because you're not gonna have a collision. These arcs, the one on the left and the one on the right, are going to hit the couch and or the patient, right? In this one, it's gonna hit the patient right on the neck here, or the head here. And in this one, it's gonna hit the couch, right? It's coming from the bottom, right? So how can you tell? Well, first look at the location of the patient, right? This is a sagittal, right? It's a sagittal plane. Okay, so that means that the couch was rotated to either 90 or 270, right? So you know the couch is here, right? So that means that when the gantry rotates, right, it's in this case, it's going to hit the patient, right? Because you're coming from the top to the bottom. Here, it's going to hit the couch, right? Or if not the couch, sorry, I shouldn't have said the couch. I've said the head frame, right? You're going to hit the head frame of the patient. You could be hitting the couch too. It just depends on where the lesion is located, right? So always pay attention to that. Very, very important. This is very easy to do when you're planning because you have a lot of arcs, and sometimes you're switching from clockwise to counterclockwise, and it's very easy to forget to, I mean, the treatment planning station will calculate the plan like this. It doesn't care. It doesn't know. It's not like that it doesn't care. It doesn't know that you're going to have a collision, right? So always verify first. And of course, that's the reason why you also do the dry run on the pace on the at the machine before you bring the patient, right? To make sure you don't have any collision. Dry run, I mean, typically when we do the IMRT QA, right, the VMAT QA, that's almost better than the dry run because you're going to see immediately if it's going to hit. All right, what about beam energy and dose rate? Okay, for cases that are non-SRS, oh, sorry, I didn't mean SBRT, I meant SFRT. For those cases, you can use 6x, 10x, and 600 MU per minute, right? For you can also use high dose rate. It doesn't matter. Actually, it'll make the treatment shorter. That's the advantage. All right. For well, but again, you have to be. I should probably say that after my next statement. All right. For SRS and SFRT, you want to use the filter-free modes, right? For energy. So the 6 MV filter-free and the 10 MV filter-free. This one has usually a dose rate of about 1400 MU per minute, right? So you can contra this to the standard 600. And the 10 has 2400 maximum per minute that you can select. All right, so what's the advantage of a very high dose rate? Well, the advantage of a very high dose rate is that it takes less time to treat the patient, which is great because then the patient is less likely to move, right? The other advantage is that you get less out-of-field dose. Why? Because there's no flattening filter, so you're not scattering all of those photons all over the place, right? It's more focused. And the other advantage is you're using an unfiltered energy spectrum, which is a lot easier to model, so it's a lot more accurate, right? So those are advantages. Now, where do you have to be careful? Well, remember, if you're not using a filter-free, if you're using a filter-free beam, it doesn't have a flat profile, right? This is the profile in orange for, oh, this is backwards.
Yeah, you see that it's inverted, Jose? That's in the chat
I just
too.
noticed. Sorry. Sorry. Orange is actually not the filter free. Orange is the, wow, I just noticed it now. Sorry, guys. Yeah. So the flat filter is for the 6X. The blue is for the filter free. I'm going to have to correct that in the next slide. All right. And you see that it's not a flat profile, right? So you have to be careful about that, right? So when you're considering what targets you have very large targets, it might not be a good idea to use it depends, right? And depends on the size of the target. Now, if the target is small, it doesn't matter because you get a very small change in intensity, right? In a small distance, right? This is centimeters, right? So you can see from like, if you're like -1 to 1 centimeter, you're not going to notice a big difference in beam intensity, right? Right. The other thing to consider is uniformity is not important for small targets, right? We don't care about it. So flatness is not that critical. Oh, sorry. That's when I went. Let me go back to this one. If you're treating a non-SRS or SBRT case, increasing the dose rate is not, there's nothing wrong with that. I mean, I know that typically we're used to seeing 600 MU per minute. You could have cases in which you could increase your dose rate, particularly if you're treating 3D. Now, if you're treating IMRT or VMAT, you have to be careful because if your dose rate is too high, the MLC may have trouble keeping up, right? I mean, the MLC leaves may have to move too fast, right, to keep up with the dose delivery. So those cases, you really have to consider it on a case by case. All right, what about the collimator angles? Okay, collimator angles are very important. The MLC rotates with the collimator, right? And depending on how you angle your collimator, your MLC leaves are going to be facing one way or another, right? You want your MLC leaves to conform to the targets and to be able to close between targets, right? So here's an example where the collimator angle chosen on the left is bad because the way the MLCs are placed, I can't block between the lesions, right? This space between the lesion where it's healthy brain is being treated for no reason, right? By rotating the collimator, right? Now I'm able to place the MLC leaves so they move this way. And now I can effectively block the space in between, right? The two lesions. This is very, very important, particularly for multi-med treatments. In the case of whole brain with hippocampal sparing, I already showed you the picture where you orient the MLC leaf so you can block the hippocampus, right? Very important. The other thing that's important to watch out for is that the small lesions are covered by the high resolution MLC leaves. If you look at my photograph here of an MLC on the left, you can see that there are some MLC leaves that are thinner in the center, right, of the MLC, and there's some thicker ones on the outside of the MLC. If you're treating multiple lesions and one of the lesions happens to fall in this area, it's going to get treated with the thick MLC leaves, which affects the conformality, right, of your dose for those lesions. You want the lesions to be in here, in this space. And then finally, do not use or try to avoid using 0 collimator angle on VMAT plans, because if you do that, you're going to get tongue and groove effects and addition of intraleaf transmission, okay? So you're basically giving more dose than you should in those areas.
Jose, if I may interrupt before you get into this slide,
Yes.
we have several questions in the chat right now.
Okay.
A couple of which are surrounding hippocampal avoidance and dose constraints, and this is a topic where we may want Dr. Lee's expertise too. So let's start there, and then we'll get into some of the more technical physics questions. So for SRS, what constraints are typically placed on the hippocampus?
Well, not for SRS, right? Because we don't treat, I don't think we treat the hippocampus. We don't do hippocampus pairing with SRS.
Hey, we tend to track it at Emory, but usually
okay.
We're achieving target coverage first, right? So we're not compromising on that based on hippocampal dose. And we're leveraging the fact that there are many non-coplanar beams and strategic optimization objectives that achieve a very sharp dose gradient. So I don't know that we're necessarily doing much about it. Dr. Lee, does your practice vary?
Don't for SRS, but if there's a lesion that's nearby, you could certainly contour. I mean, we do gamma knife, so it has a very steep dose fall off regardless of how we're doing it. So for LINAC, it may be different. That makes sense. We'll put limits for serial structures that we're worried about, like optic nerves, or we'll prescribe to a lower dose if it's in an eloquent area.
And there's a follow-up question also regarding hippocampal sparing in terms of dose constraints in the case of 30 gray. And I believe that that's actually most of what has been published in the literature in terms of hippocampal avoidance in the context of whole brain RT.
Well, the one thing I would mention is that the most important thing is the number of fractions, right? Versus the actual dose, right? So when you're looking at constraints, always make sure you're looking at constraints that are appropriate for the number of fractions that you're delivering. Unfortunately, I don't really have answers about the hippocampus for SRS because I mean, honestly, I'm going to start looking at it now, but I've never actually looked at it prior, so.
Okay. Now let's move on to a couple of more technical questions. And here's the first. Is it better to use 10 flattening filter free in treatment, I think generally? And this may be as opposed to say 6 triple F. What are the considerations there if you have the choice between the two?
Yeah, I may have not. I mean, I think yeah. I mean, if you're treating in the previous slide, I didn't read this one, but if you're treating with lesions that are superficial, 6X should be 6 FFS should be sufficient. If they're deep, you might get a better plan with 10 FFF. So I mean, to me, that would be the consideration for deciding which one to use. You may just do a plan with 6 and one with 10 and compare, I guess, if you have any doubts. Most of the times, I mean, in my experience, most of the lesions were pretty close to the, with exceptions, right? I mean, sometimes, well, if you're treating brainstem, I guess, right, then you're deeper. But yeah, I've rarely used 10 FFF. That doesn't mean that you shouldn't. It's just that in my experience, I've rarely used it.
And a follow-up question is regarding using IMRT. What is your recommended dose rate to avoid the point where the MLC has to move so fast that it may result in poor patient-specific QA?
Yeah, I don't know if there's a like a rule of thumb or a mathematical formula for calculating that, if I'm being honest. I'm not sure. It would be,
At Emory, we go as fast as possible.
yeah, I mean, that I was just gonna say that just try it. You're gonna know when you do the QA is when you're gonna see it. Is when you're gonna see that you're not getting what you think, what was planned is not what you're getting, right? You're gonna see a lot of failures.
And Jose, could you very briefly explain the tongue and groove effect? So what does that mean?
All right, so if you think about the MLC leaves, right? If the space between the leaves is always overlapping, right? Then you're gonna get areas on your dose distribution that are gonna be much, basically you're adding all those transmissions through over the same area, right? That's basically the way I look at it. The other thing too is you have the rounded tip of the leaves. So when you close the leaves completely, you still have a space, right, where you can get transmission, right? So if you have areas again where you're overlapping those, then you're gonna get areas with higher dose. So you're gonna get hot areas, or you're gonna get cold areas depending on whether you're blocking or you're adding, right? So that's usually when you look at the IMRT QA, you're gonna know you have tongue and groove, because typically you get like straight lines of cold points or hot points. That's usually how you know that you're experiencing tongue. Probably not a very good explanation. Sorry.
I think we can move on with the presentation.
Okay. All right. So we've looked at energy, dose rate, the arcs, the angles, the collimator angles. Why do I have to look at the BMI view? All right, well, you want to look at everything. I mean, you want to look at the BMI view. So why do you want to do that? Well, you want to make sure that the collimator settings were set appropriately for what you're treating, right? Here's an example on the left of a single metastasis that we're treating, and you see that the jaws are very nicely closed around the area where you're treating. The jaws, right, at the X and Y, right, in your machine. The MLC leaves are going to be modulating, right? But you always want to block behind the MLC leaves. Why? Because you don't want the transmission, right? And the interleaf transmission, right? To add dose to areas that shouldn't be getting that dose, right? And then on the right, you have an example with 2 lesions, right? The collimator size is set by the dosimetrist during the plan, right? So it's unless you have hyperarc, I guess, or some fancy or elements, Brainlab elements, it's not set by an algorithm. It's set manually. You do have the option in Eclipse for Eclipse to calculate, like you can tell it what you want to conform it to, and you can even give it an extra margin around that size to do that. All right. And then the other thing that's important, I mean, this is particularly important if your treatment planning system doesn't have jaw tracking, right? Jaw tracking means that as you're treating the patient, as the arc is moving around the patient, the MLC jaws are closed. Sorry, the MLC jaws, the jaws are opening and closing around the area that you're treating. So sometimes they're smaller, sometimes they're bigger, depending on where the aperture, the opening, right, in between the MLC leaves is located. But this is important because it's in some cases, if the dosimetrist or the person who planned it made a mistake, the jaws are going to be closing and blocking part of what you're trying to treat, right? It doesn't mean you're going to get a bad plan if you do that, because you have a lot of arcs and angles. So one of those is going to be able to treat the target, but it's not optimal, right? You're making it more difficult for the treatment planning system to give you a good plan. All right, the other thing is the modulation factor, right? The modulation factor can be calculated like this. You open your treatment plan, you look at the MUs for your treatment fields, you add them, and then you divide it by the fractional dose. So if you're treating 900 centigrade, then you divide by 900. If you're treating 300 centigrade, then you divide by 300, okay? That's it, and so you get a number, right? It's a number that runs from whatever 1 through 10 if you want. So ideally, you would have a spreadsheet or some kind of a document where you have a summary of what you expect to see for different treatment modalities and treatment sites. So you would have breast, lung, brain, whatever, SRS, non-SRS, right? And then you would use that to determine if you're getting the modulation factor that you expect. Okay, so why does this matter? If you have a very high modulation factor, that typically means that the treatment planning system is working really hard, too hard sometimes, to get you what you want. And sometimes the machine cannot do that, right? We were just talking a moment ago about the dose rate and when do you know that your dose rate is too high and the MLC leaves can't make it? Well, you're going to definitely know it when you look at the QA plan. This is an example of a QA plan. You can see you have a lot of hot failure areas, right? So that's usually an indication that you're pushing that plan way too hard, right? The machine is not able to deliver that plan. And if the plan is not deliverable, you shouldn't treat with it, right? So what are you going to do? You have to go back to dosimetry and say, okay, let's ease up on the constraints, or let's look for it, maybe add more arcs. There may be different strategies that you can use, or maybe decrease the dose rate, right? I mean, you have to make a decision and experiment and see what works the best. All right, so we're now ready for question number 4 in our poll. Which of the following is not found in a high quality brain plan? Arc beam that results in a direct incidence to the eyes, collimator oriented, so a maximal number of MLC leaves cross the targets, OARs only receive exit dose, catch angle selected to avoid inter-target shadowing, good balance between number of beam marks and delivery time. Okay, so here you're looking for what you do not want. A lot of these things you want, but there's one that you do not want. And the key factor here is high quality, right? You can have a lot of clinically acceptable plans that may have all of these things, or some of these things may be missing, right? But we're looking for the high quality. We want the best plan for this patient.
Okay, it looks like we have a great response rate right now. I'm going to end the poll and share the results.
All right, so I can see that about a little bit over half of the people who answered selected the first one. Yeah, that's true. Yeah, you do not, actually, let me see. Sorry, it's hard sometimes to, yeah, that's it. You do not, if you add, when possible, so you may have some cases where you just can't avoid it, right? But if you can, you should always avoid going through the eyes of the patient, okay? I just want to mention that even if you go through the eyes of the patient, your lens dose and your orbit dose may be acceptable. But what's not acceptable is that you're giving it dose when it shouldn't be getting any, right?
Jose, there's a question in the chat which
Okay.
is related to the modulation factor. And could you briefly repeat how that modulation factor is determined?
Yes. All right. So
what's the division?
Yeah. So you open the treatment plan, you look at the plan, and for each field, it is going to tell you how many MUs are going to be delivered. You add them. So if there's 3 fields, you take the first MU, add it to the second, add it to the third. So you get a large number, and then you divide it by the fractional dose in centigrade. All right, so if you were doing conventional fractionation, it would be 180 centigrade, right? For SRS, it's usually more like 900, right? Centigrade. So you divide those to the sum of the MUs by the fractional dose, and you're going to get a number, right? And that's your modulation factor. I think I forgot to mention, actually, I'm glad we went back to this one. If you don't, obviously, when you start collecting these, you're not going to have any number to go by. Use 4. 4 is a good, like, rule of thumb. If your modulation factor is less than 4, typically you're okay. If it's more than 4, that means that something is, you're pushing your system a little too hard. But it depends. I mean, this isn't set in stone, okay? But I'm saying, while you're collecting your own data for your clinic, 4 is a good place to start.
And Jose, along that thought, does the lack of robustness mean that a plan looks good on the treatment planning system, but it's not able to pass the QA about being too complex or too demanding on the machine? That is, these MLC apertures are getting smaller and smaller where the beam modeling is not quite as good, and that's why the QA pass rates go down?
Yeah, it's the robustness has more to do with the latter of what you were saying. It has to do with how accurate your dose actually is, right? So that has to do with modeling. And of course, when you have a high modulation factor, you have a lot of MLC. You will see that if you look at the MLC, you will see there's a lot of apertures that are very, very small. And you know that it's very difficult to to measure and calculate output factors for very, very small apertures, right? It's going to be very inaccurate. So the more of those small apertures that you have, the more inaccurate your dose is. Okay, your calculated doses in the plan.
Jose, another question. What's the maximum number of beams that you would typically use for a stereotactic radiotherapy plan?
It depends on how many targets you have. For one target, I usually use 2 non-conformal arcs and their partial arcs. So if the target is on the left or on the right, I just shorten the arc on that side. If you have 2 targets, you may be able to get away with 2 arcs typically, if not 3. I don't think I've ever had to use more than maybe 4 or 5 arcs. And the reason for that is once you start getting to 4 or 5 arcs, now you're looking at probably an hour or 45 minutes to treat the patient, right? So you have to consider those things. If you need more arcs to get a better plan, you may want to consider separating the lesions into 2 groups and treating them with separate isocenters.
Our experience at Emory is fairly similar. We use HyperArc for most of the SRS plans, so by default, it's up to 5 arcs, which are 180 degrees. So that would be the upper bounds. An exception in which we would use a greater number of arcs would be for cone-based SRS, say for trigeminal neuralgia, in which case we use 8.
Yeah, but that's cones. Yeah, I've only worked in cones in one of the centers that I worked at. All the other centers were doing Linac based, so yeah. Yeah, cones are more, you get a better penumbra, better sharpness of your fields. I mean, it has a lot of advantages, and for sure, for something as small as trigeminal neuralgia, I would not feel comfortable treating with anything but cones.
Thank you, Jose. I think we can move on.
All right, and I know that this presentation is going really, really long, so let me see if I can shorten it a little bit. All right, so the next thing you want to look at is this is more of the stuff that you guys are probably used to, so I'm not going to spend as much time here, but always look at your objectives, right? The objectives that were used by the dosimetrist in treatment planning. If your center is using templates that have been approved by your department, then all you have to check is just to make sure that the correct template was used, right? Of course, the dosimetrist has freedom in varying the objectives, right? So just keep a look at that. But the most important thing is for when you're treating SRS and SFRT, the targets should only have lower objectives. I don't really see a reason why you need an upper. And the reason for that is the objective of the SRS SFRT treatment is to establish very, very steep dose gradients. And you're not going to be able to do that if your hotspot is restricted, right? Expect very large hotspots for these types of plans from 120% to 160%. It's not uncommon. At most of the centers that I've worked, we've always tried to keep the hotspot around 120, 130, but again, it's going to depend on case by case. Look at your OER objectives, organ at risk, right? OER. Always make sure that they satisfy the departmental guidelines and RTOG and whatever documents you're using. Now, when you're looking at the objectives for organs at risk, you don't want the objective to be equal to the tolerance that you're going for. You actually want it to be much less. Why is that? Well, because what if you have to, even though, let's say that you have a plan where all of your organ at risk tolerance are just below the tolerance, right? It's a good plan, right? You're meeting all of your goals and constraints. Well, what if this patient has to come back for treatment again? Now you're in trouble, right? Because now you're so close to the edge of acceptance of tolerance that you're gonna have a really difficult time meeting constraints. Protecting these structures, right? So always use what we call ALARA, as low as reasonably achievable, right? That's what that acronym means. So it's not, don't just stop pushing when you get below the tolerance. Keep pushing way below, as far as you can, to the point where you're actually causing a loss in coverage, right, on your tumor, right, on your target, because you don't want that. Now, this is important. If you have an organ at risk that it's abutting means it's next to, or it overlaps, right, a target, you're not going to be able to meet the constraint. It's not possible, right? Because you have to treat the PTV, right? So this area of overlap between your blue circle, which is your organ at risk, and your PTV is going to get full therapeutic dose. So what can I do? Well, what you do is what is recommended in ICIU report 83. You're going to contour the overlap separate from the area of the organ at risk that is outside of your target, and you're going to apply looser objectives to the area that's inside the target. Okay. Now, it's not just good enough to have objectives. It's important for these objectives to be prioritized. What does it mean? Well, some objectives are more important than others. For example, like protecting the spinal cord is always at the top of the list, right? That's usually a constraint that you never want to exceed, right? So there is a series of importance, right? Now, you don't get to make that decision by yourself. This is a decision that has to be made as a department, right? Your physician will have, a specific prioritization that he or she may want you to use in your treatment plan. So you have to make sure that they are met. This is an example that I'm showing you here for ECLIPSE. In ECLIPSE, you have what is called ECLIPSE clinical goals. And you see that you have most important, very important, important, less important, and report only, right? So you can organize your constraints based on what's the most important to what's less important. So what's very important has to be met. What's less important, as long as you've met the very most important, then you should be able to meet this one, right? That's how that works. Always look for missing objectives. If there's structures that were not placed there, you have to question why were these structures not used? Structures that should always be there are PTVs, rings, and normal brain minus PTV. Other ones, it depends on the case, right? Now, in the case of SRS and SFRT, if the targets are far from organs at risk, usually you don't put them in the optimization. Why not? Your gradients are going to be very, very steep. Here I'm showing you two examples of a SRS case near the brainstem and near the eyes, right, of a patient. And you can see that the dose fall-off is occurs very, very quickly, and you're getting very low dose, right, to those structures. So you're not going to exceed the tolerance for those structures, typically. Okay, I'm not saying don't all, it's not one size fits all. You always have to consider each case. I mean, if this is a case where the patient was treated before, you're going to have to consider that prior dose in addition to this low dose path that these structures are getting. But typically, you don't have to put them in there. Now, if you're really concerned about the spinal cord, the brainstem, then you should include it in the optimization. Okay. All right, this one is a little tougher. When I created this slide, I wasn't quite sure how you can do this, but conflicting objectives, right? When you're planning, this is an example from ECLIPSE. When you're planning, it will show you a graphical representation of your objectives, right, for different structures. And at the top, it's going to place the ones that is having a tougher time meeting, right? So it's having a tough time with these two, right? The inner ring and the PTV. Well, this makes sense because the ring is trying to constrain the dose around the edge of the PTV, right? And the PTV wants to loosen that constraint because it doesn't want to get too hot, right? So that's why these two are fighting. The problem is you cannot see this once the plan has been finished. That information disappears, so there's no way to investigate this. The only treatment planning system where I know you don't have this issue is Pinnacle. In Pinnacle, it will actually show you a table of values that are calculating, and the magnitude of those numbers indicates whether or not a constraint was harder to meet or not. An objective, sorry, was harder to meet or not. So my recommendation for this is just always familiarize yourselves with the tools available on your treatment planning system for this purpose. You may not, like for example, in the case of ECLIPSE, you may not be able to. Actually, you can't. You cannot evaluate this. So what do you do instead? Well, instead, look at the structures, right, and see which ones are close to the target. Structures that are close to the target may be causing problems for target coverage, right? So always look at things like that. All right. Gradient tools, very, very important for SRS and SFRT. We want very, very steep gradients. And you can achieve that using the normal tissue objective. That's what NTO means. Or the use of rings. Here's, I give you an example of rings, right? You have the PTV is the target in, sorry, the smaller circle. This orange band is your inner ring. And then you have this outer ring in green, right? So you're going to push these to by different priorities to push the dose away from healthy brain and all towards the target, right? This is where you want most of your dose, right? And that's what's going to give you a very, very steep gradient. In treatment planning systems like BrainLab Elements and HyperArc, these rings are handled internally by the algorithm, so you don't have to draw them. But if you're doing it in just standard Eclipse, you have to draw these structures, right? And there's guidance for how to draw these structures in the paper I gave you by Popple on VMAT. All right, here we are on our fifth simple question. True or false? One should only review the parameters used in the optimization if some target goals and or OER tolerances are not met. You want to?
Okay, looks like we have a great response rate. I'm going to end the poll and share the results.
All right, so most people chose false. All right, let's take a look. Yeah, false is the correct answer. Why is that the correct answer? Remember that the objective of optimization is not to meet the target goals and the OER tolerances, but to exceed them, right? So we want to keep the OER doses as low as reasonably achievable, ALARA, right? We want to push on those OERs up to the point at which you're beginning to compromise the target goals. That's where you should stop, at that edge, right? OERs excluded from the optimization may not be optimally spared, right? So if you don't look at the optimization and you don't look at what was optimized, you may not necessarily know why that is, right? Conflicting objectives can lead to reduced target coverage, right? Poor implementation of ring structures can result in unnecessarily high doses to normal tissues, or even doses that are under tolerance, right? And tissues that are not contoured are not evaluated by the dose volume histogram, right? So you have to be looking at all of these things, making sure that that is the case, right? Optimization objectives are not immune to typos. It's easy to make a mistake, right? You meant to write a number and you switch the digits, right? So all of these things are important, right? And some optimization objectives may not agree with the consensus tolerance or your department guidelines, right? Due to a mistake, right? So always look and make sure. Dose distribution. Right, prescription and normalization. Always verify your planned prescription and normalization methods are appropriate. And I'm giving you some references here because the answer to what's the correct prescription and what's the correct normalization depends on what you're treating, right? Right. Always check your dose calculation algorithm and grid size are appropriate, right? Monte Carlo algorithms are usually preferred for SRS and SFRT. But convolution superposition algorithms like AAA are also acceptable, okay? And I'm giving you a reference to a paper where they discuss that. Always remember that many brain structures are very small, so your grid size needs to be small. Also, it needs to be small because sometimes your targets are small, right? So if a lesion has a volume of less than 3 cubic centimeters, you should be using 1 millimeter dose grid, okay? Now, grid size affects spatial resolution, but it also affects how long it takes to compute. I think this is more of a thing in the past, honestly, because I don't notice too much of a difference. Sometimes you do with Monte Carlo, but I don't know. It's not a huge. It's not so much of a. Maybe you have to wait an extra 5 minutes. You know, it's not usually something that is terrible. All right, here's an example of something that happened to me that is very important. Something that you wouldn't think to check, right? And that has nothing to do with treatment plan quality or any of the other factors, but it's more of a bug in the program, right? So Eclipse, if you have version 16.1 or previous to that, there's a bug in the program. When you look at your calculation options for Acuros, see how it says calculation resolution in centimeters 0.25, and then it says calculation resolution in centimeters for SRS and HyperArt 0.125. Okay, so that would be 1.25 millimeters, 2.5 millimeters. Now, if my beams are SRS beams, my expectation is that it's going to use 1.25 millimeters for the dose grid. But because of the bug, it doesn't always. So here I had a case where I thought I was getting 1.25 millimeter dose grid, but it actually used 2.5 millimeter dose grid. And you can see in the DVH, it makes a difference with your GTV coverage. Not as much with the PTV, but definitely with your GTV, right? So these are things that you don't think about, but sometimes are very, very important. So always check your dose grid. Always check that the correct dose grid was used, and also always check that the correct algorithm was used. All right, target coverage and conformity. All right, for all brain plans, always, and actually for any plan, not just brains, always look at the isodose line distribution slide by slide. I know it's very tempting to just go to the DVH and go, everything looks good, let's go on. Always look at the dose, please, because there are some things that the DVH is not going to show you. Like here's an example, right? So you can see that you have two plans, one where the dose has a lot of spillage, right? You see that the dose spills out of the target, right? I mean, you're not hitting any OARs that are getting any dose that the DVH is showing, but this plan is not very good, right? It should be a lot more conformal, right? So in this case, looking at the 30 gray isodose is always a good way to check for non-SRS SRT cases. Here you have some SFRT plans. There's two of them, one at the top, one at the bottom. In both of these plans, the target coverage is very good. But you see the problem, right? The bottom plan has a lot of dose spilling out of the targets, while the top plan is very nicely conformal. All right, just something to look about, to consider. The way this happens is no rings were used in the bottom plan, okay? While rings were used in the top plan. The other thing to look for, especially for multi-med cases, is what is known as island bridging. And island bridging happens with, if you remember that slide that I had with the MLCs not blocking the space between the two lesions, that's how this happens, all right? So always look at your collimator angle, make sure the MLCs are able to block in between the lesions, right? If they didn't, that's the reason you have island bridging, right? And if that's not the case, if there's another reason, you could always create a structure in between the two lesions, right? And then include that in your optimization. Now for SRS and SFRT, we have specific metrics that are used, all right? One of those metrics is called the gradient index. And the way you calculate the gradient index, you take the volume of your 50% isodose volume and you divide it by the volume of the prescription isodose, which is your 100%, right? That ratio ideally is less than 3 or between 3 and 4. Now I'm showing you a graph here with gradient indices for different sizes of PTV. And you see that as the PTV gets smaller, this ratio explodes, right? You're not going to be between 3 and 4 if you have a very small lesion. You're probably going to be more like in 6, 7, even 10, right? So that's just something to consider when you're looking at this constraint, right? It's not going to be valid for very, very small lesions. The Paddock Conformity Index gives you a sense of conformity. Conformity means how well does the prescription enclose or envelop the target, right? I'm going to start from this part where it says, do not use the RTOG definition for conformity index. Why not? Why don't you not want to use this? Well, the conformity index in RTOG is calculated as the volume of the prescription divided by the volume of the PTV. Here's an example where I'm drawing a target and a prescription isodose that have exactly the same size. But notice that only half or less than half of the target is covered by the prescription. When I calculate the conformity index with this ratio, I'm going to get 1. But I am not getting 100% of my target covered by the prescription, right? Why am I getting 1? Because they have the same volume, right? So that's why you don't want to use this. The PADI conformity index fixed that by including this term at the top. See this V Rx PTV squared? This is the volume of the PTV that's inside of the prescription isodose, right? So that's going to be in the numerator squared, and you divide at the bottom by the volume of the PTV times the volume of the prescription isodose line, right? This is a much better metric for conformity. It should typically be between 1 and 2. If it's 0.9 to 1 is considered a deviation. Oh, sorry, 9 to 1 or 1 to 3.5. And if it's bigger than 3.5 is considered unacceptable, okay? Here's another metric, R50. This is exactly the same metric that we use for line SBRT. It's the same thing, right? You take the 50% isodose line and you divide it by the volume of the PTV, right? Ideally, this metric should be between 3 and 6. But again, just like the gradient index, when the volume of the PTV is very small, this blows up, right? So you're going to get the same situation that you're seeing here. So don't expect to get 3 to less than 3 when you're treating a 1 cc, a 1 cubic centimeter target, right? I'm giving you some references here where they explain all of these metric indexes, right? And metrics, right? So make sure you get these so you get a much more detailed explanation, and you'll get the, you'll see where I got this graph. I got it from one, I think I got it from, I don't remember, one of these. All right, hotspots, right? Hotspots are very important too, right? Always see where it falls. Where's the hotspot and how big is it, right? Also look for high dose streaking, right? Like I showed you before. For non-SRS and non-SFRT plans, the hotspot is typically like around 110 to 115%, right? However, for SRS and SFRT plans, the hotspot is going to be very large, right? 120 to 160%, so do not freak out. But what you want to look for is that it's ideally inside the GTV. See the hotspot in this picture, that gray area? That's where my very, very high dose, my 120% is. It's inside of the GTV, right? The outside red line is the PTV. Now, if that's not the case, if it's in between the GTV and the PTV, that's fine, as long as it's not outside of the PTV, okay? But ideally, inside of the PTV. If it's not, that means that the inner ring that is used to push the dose inside of the PTV was not used optimally in the optimizer. Okay, so you have to look and see what priorities were given. The other thing is the dose gradient. Okay, here's on the left I have a dose gradient for SRS SFRT, and on the right I have a dose gradient for non-SRS SFRT. Right. So dose gradient for SRS and SFRT is very steep. So it should be like 5 to 10 millimeters per, sorry, 5 to 10% dose. That's what that means. So change in percent dose of 5 to 10 in 1 millimeter, right? For non-SFRT, it's about the same dose difference, but per centimeter. See, so it's a big difference, right? This is less, this is a more gradual increase in dose, right? This is a very sharp fall off, right? Which is what we want for SRS and SFRT. So how do you measure this? Well, most treatment planning systems have something called a dose profile tool. That's what this red line is. You draw a red line across the target and you get these profiles, okay? And you can measure your gradient based on that, right? Organ at risk sparing. Okay, you have to, this is of course something that we do for all the plans, right? Make sure that all the organs at risk meet the constraints. For non-SRS and SFRT, follow RTIG, those constraints. For SRS and SFRT, we refer to high-tech, right? The Timmerman tables, make sure they're the 2020 ones, which are the updated ones, and or AAPM TG101. Okay, I think TG101 doesn't have the updated tables. I may be wrong, but always make sure if you're looking at Timmerman tables, make sure it's 2020. Organs at risk doses should be as low as possible without compromising treatment outcomes.
It is not acceptable to stop optimization when OER doses are just below tolerance. That's what I said before, right? ALARA, as low as reasonably achievable. For looking at constraints, I'm going to give you a fantastic resource. You definitely want to download this. You'll thank me. All right. So if you search your apps in your phone or your, for Radonc Calc, it's by Jeff Rickman, right? This is their website. This is an excellent resource for looking at those constraints. This person, Jeff Rickman, is actually a physicist that became a radiation oncologist, and he became aggravated and annoyed at the fact that he always had to look at 20 different papers and tables to figure out what constraints to use. So what he did is he's created this app that has all the constraints. It shows you where they came from, RTOG, high tech, whatever it is. You just have to type the organ that you're looking for, the number of fractions, and it will give you the correct constraints to use. Very, very useful tool. All right, for SRS and SFRT for normal brain, if it's a single fraction, you're going to use V12. That's the volume of normal brain that's getting 12th grade. If you're using 3 grades, you're going to use V20. And if for 5 grades, you're going to use V24. Okay. And then here I give you a recommendation. If single fraction tolerances cannot be met, suggest a fractionated schedule. All right. That would be the first suggestion. If that's a no, then consider lowering the target coverage. If that's a no, then consider lowering the prescription. But that should only be the last resort. It's typically you never get to this point. All right. Like I mentioned previously, you have to know if the patient has received prior radiation. Okay. Always confirm and see if the patient has received prior treatment. When you're adding the doses from plants, you have to make sure that you're comparing apples to apples, right? So you cannot compare plant physical doses that were given with different fraction sizes. So how do you compare those? How do you add those? You convert all of them into 2 gray per fraction dose equivalent. I give you the formula down here, right? N is the number of fractions. D is the fractional size, right? The dose that you're giving each day, right? Alpha over beta is the parameter that has to do with the tissue that you're looking at, right? Tumor versus normal tissue. Now, the challenge with this is that most treatment planning systems do not give you a way to work with biological dose. You can only work with physical dose. So you may have to use third-party software such as MIM software or Velocity or some others that I'm not familiar with that allow you to convert physical dose into biological dose to add it. Now, if you don't have an option to that, because these softwares are very expensive, and maybe your clinic doesn't want to buy them, that's okay. You can always do a manual calculation, right? Using what they call near maximum doses. All of that is explained in this paper right here by Paradis et al. Right? So if you download this paper, they tell you exactly how to do it step by step. And if you don't like reading, if you like watching, then go to the webinar series, because Dr. Paradis actually presents one of the sessions and explains how she does her re-radiation calculations. Okay, so very, very, very important resources, these two. All right. All right. I know that the data that I'm showing you here is not for brain, but unfortunately I couldn't get any brain case, but this is just to show you what happens when you add physical dose versus biological dose, right? The dose that is in the dashed line, right, is a biological dose. The dose in the solid line is physical dose. So you see that if you add physical dose instead of biological dose, you're not getting the same numbers, right? It's not the same. Look at the OERs, look at your targets. Everything is different, all right? Very, very important that you convert to biological dose. And I will tell you something else. If the dose per fraction is 180 or 2 grays per fraction, still converted to 2 gray per fraction. All right, I think it is our last Zoom poll question. Do you agree with this statement? And this is a statement that I have heard from a lot of physicists that I worked with. If the physician approved the plan, then it is clinically acceptable. I am not qualified to know what prescriptions, target coverages, or normal tissue tolerance should be used. I should go with whatever the physician chooses. I don't have a medical degree. This isn't there's no correct or incorrect way. Sorry, there's no incorrect way to answer this question. It's just how you feel about it. Right? It's your personal agree or disagree.
It looks like we have a good number of responses right now.
All right.
I'm going to end this poll and then share the results.
All right, so you can see there's quite a big breakdown of answers here. Most of them are between the disagree and the agree. All right, so let's see what I think, right? Because I'm just going to show you what I think. I mean, like I said, this is more of a personal, but I'm going to show you my rationale for my choice. Now, I disagree with that statement. Why do I disagree? Right, because we all, physicians, dosimetrists, and physicists, we have a shared responsibility for the quality of the treatment plan. It's not up to only one person. No one in the radiation team is infallible. We can all make a mistake, right? I don't know if you've ever shadowed a radiation oncologist. I have a lot of respect for what they do because they have to remember patients and details of information for all of these patients that they see every day. They move like a pinball from one place to another, from one room and then into the vault and then into the HDR room. So it's very easy to make a mistake. All right. So and they're gonna look on you for support. Right. So it's not possible or expected for one person to remember everything. Right. Be humble enough to ask for help when you're unsure or simply do not know. Discussions of plan quality should be conducted in a non-threatening and respectful manner. This is very, very important. Right. The word medical is not accidentally included in the title of your degree, right? You're a medical physicist. You are not an MD, right? Obviously, we've had different training, right? But you do have a medical degree. It says medical on it, right? What does this mean? You must have at least basic knowledge of the medicine, anatomy, and physiology. And if you look at your course requirements or courses that you have taken, you took courses on radiation biology, human anatomy, and physiology, right? That wasn't accidental. All right, these last two slides are common. You're going to see them in all of the presentations. And I apologize, this session, I knew it was going to take a long time, but I didn't think it was going to take this long. So my apologies for 2.5 hours. Okay. All right. So it's always important to keep, to communicate with your team, right? I have some examples here of what situations in which you should be communicating. My recommendation to you is try to be present when you can during patient treatment. All right. That will give you an option. That will give you the opportunity to observe the therapist when they're setting up patients, when they're working with the patients. You'll understand their workflows a lot better. You'll learn a lot. And because you're there and you're talking to them, you'll establish good collegial lines of communication with them. So they will be more open to communicate freely with you, right? When they're not sure about something. Very, very important. Incident learning, this is more of a departmental decision, right? It's something that you have to decide as a department, but I'm giving you some examples here. You should definitely always record deviations and events, right, that have occurred where something happened with a patient that didn't go as intended, right? You could be recording these incidents in a spreadsheet or a piece of paper, I don't know, or better, my recommendation is to use a free database resource, such as the ones that I'm providing here. For the US, we have ROILS by Astro APM. In Canada, they use NSIR-RT. All of these acronyms mean something, but I don't want to waste your time. And then international, you have SAFRON. SAFRON is maintained by the International Atomic Energy Agency, right? So this is worldwide. If any clinic from any part of the world can use this system to log and learn from incidents that occur at their clinics. The most important thing that I want to leave you with is when you're discussing incidents, avoid finger pointing. This isn't, it's your fault. How did you do this? We work as a team, right? So if something failed, it's not that one person failed, the team failed somehow, right? And if it's not the team, it's the system that is in place, the safety system that is in place failed, right? There's a hole in our net that we're not catching something. Always be respectful and empathetic, okay? empathetic. Like I said, if you're present when the therapists are treating patients, you'll be more understanding of the challenges that they face, right? So then when you're reasoning things or you're trying to figure out ways to resolve these issues, you're taking that into consideration. Right? Just always remember that when an error occurs, we're all responsible, okay? Because we function as a team.